All right. So next, we will move on to our upper limb lecture, the second session. I would like to introduce our next speaker, Dr. Teck, and also Dr. Khairul, who will be sharing the demo for the blocks. So Dr. Teck is an anesthesiologist in Hospital Kuala Lumpur and is currently a trainee in Regional Anesthesia Subspecialty Program in HKL. He graduated from University Science Malaysia and did his master's in University Malaya. As for Dr. Khairul, he is also an anesthesiologist in HKL, has a fellowship in regional anesthesia from Kiorin University Hospital. He graduated from University Science Malaysia and did his master's in UKM. So please welcome Dr. Teck and Dr. Khairul Izam.
A very good morning to all the participants. My name is Dr. Teck, and it's my pleasure to be part of the ultrasound-guided regional anesthesia workshop. Today, I'll be talking about ultrasound-guided regional anesthesia for the upper limb. The content of my talk would be basically the brachial plexus block at 3 different levels, mainly the supraclavicular, interscalene, and axillary level. After each presentation of each approach, there will be a short video demonstration. So first of all, we look at the supraclavicular approach, also known as the supraclavicular block. So the supraclavicular block is actually indicated for an anesthesia or analgesia for the shoulder, arm, elbow, forearm, as well as the hand. So how do we place the transducer to find the brachial plexus at the supraclavicular fossa? We need to place the transducer over the neck, superior to the clavicle, at the midpoint. Then after that, you need to tilt your probe, either cranially or caudally, to obtain a cross-sectional view of the subclavian artery. This picture illustrates how we place the probe in the supraclavicular fossa to obtain a view of the brachial plexus. So you tilt your probe either cranially or caudally at the supraclavicular fossa. So what are we trying to look for? Because the subclavian artery crosses the first rib between the insertion of the anterior and middle scalene muscles, we can actually observe the first rib and pleura lateral and deep to the subclavian artery. And the brachial plexus would be posterior and superficial to the subclavian artery. So how do we differentiate different structures? So the subclavian artery will be anechoic, round and pulsatile, while the rib is an acoustic shadow. And the pleura will have a sliding sign, whereas the brachial plexus would be hypoechoic nodules. This is a picture illustrating the ultrasound anatomy at the supraclavicular level. Here, we have the subclavian artery and a linear hyperechoic line with acoustic shadow, which represent the first rib. The pleura, which has sliding sign, and the brachial plexus. How do we perform the block? The block is usually performed using high-frequency linear probe and a short bevel block needle, usually 21 to 22 gauge. The needle length should be about 50 to 100 millimeters. We use an in-plane approach from lateral to medial injection. The usual local anesthetic volume is about 20 mils. The aim is to inject local anesthesia around the brachial plexus. This is a picture to illustrate the needle approach to the brachial plexus. First, we will insert the needle between the first rib and the subclavian artery. The second needle will be superficial to the brachial plexus. So afterwards, that should be the block. All right. We need to be cautious when performing this block because sometimes there will be artery that will go through the brachial plexus, mainly the dorsal scapular artery, the transcervical artery, and suprascapular artery. This picture illustrates that actually it is a brachial plexus at the supraclavicular level, but actually there's a dorsal scapular artery that goes between the brachial plexus. And in this case, this block is very difficult to be performed. Usual complications of this block includes accidental intravascular injection, local anesthetic toxicity, and also pneumothorax. Now we will go ahead with the video demonstration of the supraclavicular block.
Assalamualaikum and a very good morning. In this video, we will show you how to perform supraclavicular block for shoulder trauma. This block can be performed with the patient in supine, semi-sitting or slight lateral position with the patient's head turned away from the side to be blocked. Place a high-frequency linear transducer superior to the clavicle at the midpoint and parallel to the neck. To achieve the best possible view, the transducer must be tilted slightly inferiorly. The goal is to see the subclavian artery in the transverse view and the brachial plexus posterolateral to the subclavian artery. The first structure we need to identify is the subclavian artery. Subclavian artery is readily apparent as an anechoic round structure. The brachial plexus can be seen as a bundle hypoechoic round nodules just posterior and superficial to the artery. Some describe the brachial plexus structure as a bunch of grapes. We also need to identify pleura and first rib. These structures are linear hyperechoic structure immediately lateral and deep to the subclavian artery. We also need to identify middle scalenus muscle on the lateral side. We are using Stimoplex 360 50mm needle using in-plane approach. To visualize the brachial plexus, the transducer is oriented in the sagittal plane until the first rib is seen deep to the plexus and the artery. So we aim first to deposit the LA at the inferior trunk of the brachial plexus. For analgesia, we are going to give ropivacaine 0.2% 10 mL at this inferior trunk of the brachial plexus. We aspirate. Once there is no blood and clear, we inject the LA. So once we have created a space, then we push in our needle at the pocket of the brachial plexus. Next, after we deposit the local anesthetic, 10 mL, we flatten our needle and the next aim would be the superior trunk of the brachial plexus. Once we feel a pop, then once again we aspirate and make sure there is no blood. We inject about another 10 mL of ropivacaine 0.2%. So total there will be 20 mL of volume. So this is the spread of the LA, and you can see the brachial plexus is flooded with the LA. Thank you.
Okay, next we will I'll talk about the interscalene block. The interscaling block is mainly indicated for anesthesia or analgesia of the shoulder and upper arm. As it doesn't really block the ulnar nerve, so it is not really useful for blocks below the elbow. So how do we find the brachial plexus at the interscalene level? Mainly, we need to look for the interscaling groove, which lies between the anterior and middle scalene muscles. So the interscalene groove lies lateral to the carotid artery and internal jugular vein. The usual depth is about 1 to 3 centimeters. Above the interscalene groove lies the prevertebral fascia, superficial cervical plexus, and sternocleidomastoid muscle. So this is a picture to illustrate the ultrasound anatomy of the interscaling groove. Usually we will view to it as, we call it the traffic light sign or butterfly sign, where we'll see lateral to the internal jugular vein, there will be this anterior scalene muscle and middle scalene muscle, and sandwiched between the two scalenus muscle will be the brachial plexus. So there are two techniques to scan to find the interscaling groove. First, the medial to lateral technique, and second, to trace back from the supraclavicular fossa. So the medial lateral technique, mainly the patient will be in the supine position with the head turns 45 degrees towards the contralateral side. Then we will put the probe at the level of the cricoid cartilage, and we basically slide medial to lateral. So this is the position where we usually do the interscalene brachial plexus block. So when we put our probe at above the cricoid cartilage, we first will view the trachea, the carotid artery, and the sternocleidomastoid muscle. As we slide our probe more towards lateral, the internal jugular vein and the anterior scalene muscle will come into view. Then as we slide our probe even more lateral, the middle scalene muscle will come into view. And in the end, we will have a good view of the interscaling groove. The other technique which I personally find more easier is to trace back from the supraclavicular fossa. So initially you will put the probe at the supraclavicular fossa to get a view of the brachial plexus at the supraclavicular level. Then you just trace the brachial plexus upwards and to get the view of the brachial plexus at the interscalene level. So this is a picture to illustrate the supraclavicular scanning at the supraclavicular level, and you identify the brachial plexus at the supraclavicular fossa. Then basically you just trace your probe upwards, move your probe upwards, and as you can see, the brachial plexus becoming the roots, and then the interscaling groove become more clearer. So the block is usually conducted using a high-frequency linear probe with a short bevel block needle, 21 to 22 gauge, and the length of the needle is usually about 50 millimeters. The approach is in plane, a lateral to medial approach. The volume of anesthesia, local anesthetic agent is usually between 5 to 10 milliliters. The goal of the block is to infiltrate local anesthetic between the anterior and middle scalene muscle. So we will usually the aim is to see the brachial plexus being pushed medially with hypoechoic spread of the LA adjacent to the nerve roots. Complete circumferential spread of the local anesthetic around the plexus is usually not necessary. We have to be careful also. At this level, also there will be sometimes an artery that transverse the brachial plexus, mainly the transverse cervical artery. This will make the block very difficult. This block has more complications compared to the supraclavicular block, mainly phrenic nerve palsy, Horner syndrome, accidental epidural injection. But however, with the use of ultrasounds, because we can reduce the volume of local anesthetic, the rate of complications has much reduced. We will move on to the video demonstration of the interscalene block.
Assalamualaikum and hi, I'm Nabila. Let's talk about interscaling block. So first of all, patient should be in a supine position with head slightly elevated and turned away from the operator. So the most important landmarks here are the clavicle and the sternocleidomastoid muscle. Patient's neck and upper chest need to be exposed, cleaned and draped prior block. High frequency linear probe is then placed transversely at the supraclavicular fossa. Brachial plexus is identified, and then the probe is moved cranially until the grape-like brachial plexus change to a traffic-like appearance. Most of the time, the final probe position is at the middle of the neck, slightly posterior to the sternocleidomastoid muscle. Then, from the posterior end of the probe, the needle is inserted, aiming towards C5 and C6 roots. Well, it is not advisable to insert the needle in an antero-posterior manner, as the phrenic nerve lies in between the sternocleidomastoid and the anterior scalenus muscle. Now, let me highlight the important structure that we need to identify when performing an interscaling block. Well, this is an ideal sonoanatomy. It shows that the brachial plexus, more specifically the C5 to C7 roots, are being sandwiched between the anterior scalenus muscle and the middle scalenus muscle. So moving medially, the vertebral artery can be seen lying deep to the anterior scalenus muscle. Another important structure that we need to take note is the dorsal scapular nerve, which lies in the middle scalenus muscle. So the linear arrangement of the C5 to C7 roots reminds us of a traffic light, or even a butterfly, with the wings represented by the scalenus muscles and the brachial plexus is depicted by the body. So now let's move on to the exciting part, which is the needling part. This is a superficial block, so the needle length shouldn't be more than 80 mm. So the needle block is slowly being advanced towards the brachial plexus, piercing through the middle scalenus muscle and then the nerve sheath. So the needle tip is placed between the C5 and C6 roots. LA is injected in a small volume, maybe roughly around 1 to 2 mL after negative aspiration. And we can see that the LA is enveloping the C6 roots. The needle is readjusted, so the LA distributed to C5 as well. So during the needling part, it is very important to ask the patient if he or she experiences any pain during the LA injection. Patient might feel pain if the LA is being injected intraneurally. Post-procedure, the things that we need to observe are the common complications that can occur in an scaling block, like hemodynamic instability if, let's say, we inject LA inside the intrathecal or epidural, dyspnea if we block the phrenic nerve, even Horner syndrome if we accidentally block the stellate ganglion. A recurrent pharyngeal nerve blockade can happen, which gives rise to a hoarseness of voice, and lastly is the last, which is prolonged anesthesia systemic toxicity. So that's gist about the interscaling block. That's all for now. Till we meet again. Thank you.
Okay, now we'll proceed to the last part of my lecture, which is the axillary block. The axillary block is actually indicated for anesthesia and analgesia of the elbow, forearm, and also the hand. Usually we'll place the transducer in a short axis to the arm, just distal to the pectoralis major muscle. So this is usually the position where we put our probe, which is, yeah. So the aim is to identify the axillary artery on the medial aspect of the arm, and at the same time we can see one or more axillary vein medial to the artery. So be careful, if too much pressure applied, then the veins will be compressed and you are unable to visualize them. So usually the nerves at this level, the brachial plexus will be in the form of peripheral nerves, which mainly the median nerve, which is lateral to the artery, ulnar nerve medial to the artery, radial nerve posterior to the artery. So, but however, all these nerve and the axillary artery will be inside a neurovascular bundle, which is formed actually by the biceps coracobrachialis, conjoined tendon of the latissimus dorsi and teres major. So the musculocutaneous nerve, which innervates the the lateral side of the forearm, is located outside this neurovascular bundle between the biceps and coracobrachialis muscle. So this is what I meant by the median, ulnar and radial nerve and the axillary artery contained inside the neurovascular bundle, which is formed by the biceps coracobrachialis and the conjoined tendon. There are many anatomical variations. So the median, ulnar and radial nerve is not necessarily arranged in the manner which I described just now. However, despite all this anatomical variation, they are all located inside the same neurovascular bundle as the axillary artery. So as long as we infiltrate local anesthetic around the axillary artery, we should be able to achieve analgesia or anesthesia for all these nerves. So how do we conduct the block? Usually we will use a high-frequency linear probe, a short bevel needle, usually 21 to 22 gauge. And in this case, we also don't need to use a very long needle. Usually a 50 mm needle would be suffice. So the injection usually is an in-plane technique, lateral to medial injection. Usual volume of local anesthetic is between 15 to 20 mils. And the goal of the block is to actually spread local anesthetic around the axillary artery. So because the nerve and vessels are close together, the advancement of a needle may require hydrodissection with small amount of saline or local anesthetic. So this is a picture to illustrate how we actually do the block. Usually we will put the needle around the axillary artery, 2 injections around the axillary artery, and another injection towards the musculocutaneous nerve. Now we will have a video demonstration of the axillary block.
Assalamualaikum and hi everyone. In this video, we are going to show you how to perform axillary brachial plexus block. The axillary brachial plexus block is relatively simple to perform and associated with lower risk of complications compared with interscalene and supraclavicular brachial plexus blocks. The indications are for elbow, forearm and hand traumas. So now let's see the technique for axillary brachial plexus block. Patient in the supine position with the arm abducted 90 degrees and elbow flexed. The superficial landmark is the axillary fossa crease. Place the high frequency linear transducer in the transverse orientation over the axillary artery at the axillary fossa. Ensure the probe is over the conjoined tendon of the teres major and latissimus dorsi. 2 muscle groups define the boundaries of the neurovascular bundle, the conjoined tendon of the latissimus dorsi and teres major under the axillary artery, and coracobrachialis muscle. There are often multiple axillary veins, but they are readily compressible and are not major obstacles. The axillary artery is the primary landmark. all the nerves, median, ulnar, and radial nerves will be located above or anterior to this conjoint tendon around the artery. The radial nerve is always lying on top of the conjoint tendon, usually medial to the artery in the 5 o'clock area, but sometimes under or lateral to in the 7 o'clock area. It is hyperechoic and almost always larger than the other nerves. The median nerve is always adjacent to the border of coracobrachialis in the 9 to 12 o'clock quadrant around the artery. The ulnar nerve is always more medial to the median nerves and lies above the radial nerve. Finally, the musculocutaneous nerve usually lies within coracobrachialis, but it is the most variable in location. It can lie anywhere along the musculofacial plane and may even be adjacent to the artery. To identify musculocutaneous nerve, slide the probe laterally to image the coracobrachialis. Remember that this nerve may be adjacent to the artery and the median nerves, sometimes giving the impression of a large median nerve. Moving the probe distally will reveal the nerve as it slides laterally in the facial plane through the muscle. It often changes shape depending on its position within the muscle. Recognizing facial layers helps with identification, especially as each nerve lies within its own facial compartments. This has implications for needling and injection. There are two methods of injection to perform axillary brachial plexus block. The first one is dual injection perivascular technique, and the second one is perineural injection technique. In this video, we will show you perineural injection technique. By using this technique, we can reduce the risk of paraesthesia and nerve injury. Identify conjoint tendon, axillary artery, and 4 main terminal nerves. Start by advancing the needle towards the junction between conjoint tendon and artery to enter the radial nerve compartment. There is often a vein in this area, but it is usually pushed aside by the blunt needle and is rarely pierced. Inject 8 mL of local anesthetic here. LA will flow along the conjoint tendon into posterior compartment, lifting up the radial nerve. Note that it is common for the needle tip to advance too deeply and pierce the conjoint tendon. Withdrawing the needle tip slightly and performing test injection will usually solve this problem. After the radial nerve injection, withdraw the needle out of the coracobrachialis muscle and redirect it towards median nerve. Inject 8 mL of local anesthetic around the median nerve. Continue with injection of LA and advance towards the ulnar nerve. An injection of 8 mL is usually enough to surround the ulnar nerve. Finally, target the musculocutaneous nerve by withdrawing the needle and shifting the probe as needed to clearly visualize the nerve. Advance to place the tip within the fascial envelope of the nerve while avoiding the nerve itself. Do not hesitate to make a new skin puncture, especially if the nerve lies very far away from the main plexus, so that the needle angle is not overly steep. Now, all the nerves, median, radial, ulnar, and musculocutaneous nerve are blocked. Our job is done. Thank you for watching.
Okay, with that video presentation, come to the end of my lecture. So with that, I thank you.
Thank you, Dr. Ng, for the lecture. Okay, now we will move on to our first pop quiz session. So to stimulate your brains and recap what we have learned in our previous 2 lectures. So we will have a short pop quiz. Please click on the link in the chat box go to www.menti.com and register yourselves. And please put in your full name and not nicknames, okay, for prize giving purposes later. Remember to register with your full name and not your nickname, yeah? Link will be in the chat box. Okay, well done everyone. That concludes our first pop quiz. Congratulations to Seng Do Hao, and we will also be giving out prizes to the second and third place as well. So that's Lee Eng Ching and Lee YC. So please contact our admin after the workshop to claim your prizes. Well done everyone. Okay, now we will have a short 15-minute break and we will reconvene later at 10 a.m. Okay, so stay tuned everyone. We will see you in a bit.